I hope my colleague Erik Fransen is in fact one of my collaborators who has had a long history of genetics in hearing loss field, and I thought it was very interesting to involve him because in the hearing loss field, of course, there's been a lot of evolution in genetics, and I think nowadays they even have like for autoburning or even benign gene therapy that's in trial with very promising results as were published in fact last week in the Journal of Medicine. So I think that we can learn a lot from the hearing loss field, how they in fact started back in the 90s, and how they've gone now into the level of whole exome sequencing, whole sequencing. But it took a long time, in fact, to identify this. And I think we also have some limitations up to the genetics factors, also always needing to have these bigger families with normal hearing patients, and of course, patients affected by hearing loss. So that's the reason why I want to involve Erik Fransen. So I hope we will soon. Anyway, I will start on environmental risk factors and, of course, also prognosis. But I put in a piece, a small piece of genetics as well, so you will not, if you couldn't come without it. Okay. So when I first looked at the environmental risk factors, I first wanted to identify what's in fact the definition of this. And in fact, the WHO has a specific definition. Any external, physical, chemical, biological, or work-related condition in the natural or built environment that increases the likelihood of adverse health outcomes or disease. So that is in fact in contrast to genetic factors, which you are born with. But of course, they can sometimes correlate. We'll see that in a moment later on in the presentation. So there can be different examples generally of environmental factors that all of us know, like air pollution. We know that it contributes to all kinds of diseases, like specifically more cardiovascular and of course pulmonary disease. Like chemical exposures, this is very relevant, of course, for the vestibular disorders, as some of you use chemicals to in fact introduce vestibulopathy, vestibular loss, acute or chronic, or irreversible or reversible. We do see this also in patients. So we have patients that have been exposed to paint, to solvents, or that were involved in cleaning tanks. We do know that they have hair cell loss and that they enter our clinic with vestibular bilateral vestibulopathy, often without hearing loss. So this is very interesting to see that it's specific to the vestibular system. So I think in chemical exposure, although probably there's a lot less nowadays because this gets monitored more heavily than in the past, we do see these patients in the clinic. Physical agents, of course, like radiation, I think it's more specific. Radiation, you can also think of like the damage of radiotherapy if you have a vestibular schwannoma or some other kind of tumor in the brain. And of course, if you're irradiating the vestibular system, you are also increasing its function, potentially also introducing hearing loss potentially. But it can also be heat and cold, probably not that specific to vestibular disorder, and then noise from urban and occupational settings. And then there's these other items that are a little bit more vague to me, like built environments or occupational factors. That can be very broad, because of course, if you are mentioning that there's not a safe environment at work, means that you can be stressed, and stress can also induce, of course, a lot of these vestibular disorders or trigger them. They not necessarily are the cause of it, but still they can in fact trigger the onset or the exacerbation of the symptoms. But also you can, it wasn't mentioned in these specific definitions, but of course you can also think of maybe viral or bacterial infections. That's also something environmental, because you could manage it in fact. So I think it's something that we need to put in this list of the environmental. Of course, talking about the vestibular system, we cannot forget about the whole anatomy of the system. And it's quite logical that if you do have a trauma to the temporal bone, for instance, that it will be able to introduce vestibular dysfunction and hearing loss or deafness. If you have a meningitis, the meningia are in fact connected to the vestibular system and the inner ear. So meningitis often introduces unilateral and often also bilateral vestibulopathy. But it can also be a labyrinthitis originating from the middle ear, from acute otitis media. That can also introduce vestibular function loss. Often this is overlooked because people are very ill. They are hospitalized for many weeks. They have been in a bed for many weeks, and then they come out, and then they are unstable. People are, so the physicians think that there might be just some overall, the physical activity level was not enough the last few weeks, so this is normal after this kind of serious disorder. Of course, it takes a while, often many years, before, in fact, they figure out that this is just vestibular loss that provokes this instability. So it's something that we all need to be aware of. And of course, in our case, for the medical students, this is in their classes, so they know about it, so they are aware of these. Okay, so I think in Maastricht, I did the first lecture, and it was in fact on the list as an ENT clinician, of course, and as a neurologist. But these are like the probably list of top 10 disorders that we see in an ENT clinic in the university hospital. And you can also link these with these environmental risk factors. So if you talk about viral infection, bacterial infection, I've talked about otitis media. This is something that we do see. It's often provoked by Streptococcus pneumoniae. Of course, this changes in the field when you introduce, and nowadays the children, for instance, in our region are immunized for Streptococcus pneumoniae. So it means that the level of acute otitis media caused by this bacteria is changing. But it means that whenever there's less Streptococcus pneumoniae, there's other bacteria that take over. So nowadays we see more Streptococcus pyogenes, or we see Fusobacterium. So they are very, very aggressive bacteria that we see after the introduction of these immunization protocols. And they also cause labyrinthitis, and they often also cause serious conditions like thrombosis of the vascular system, but also ventriculitis. So that means that there's an infection that goes in the ventricles, which has a high mortality, often in children. So this is something that we do see after the COVID pandemic. So we don't know exactly whether it's the COVID pandemic that changed the microbiome, or is it maybe because of the immunization, which also around that time was changed, the protocol in the children. But it's specifically something we have in our clinic often. And of course, it can also provoke a meningitis, which in that case can also provoke the vestibular symptoms, but also the other way around. You can also have a Streptococcus pneumoniae meningitis that arises from the nose, for instance, from another part of the airway system, and in effect then produces a meningitis, and then indirectly you have a vestibular loss, but there was no acute otitis media. So this is something that is very important to think about, and specifically bacterial infection is a very important part of that we can manage by, of course, treating them with antibiotics as early as we can. And nowadays, of course, we are trained to use as minimally the antibiotics as possible, and that's also maybe a reason why we see a lot more of a serious condition, because maybe the children would have been better that they had antibiotics earlier. But of course, nowadays our GPs and pediatricians are trained to do that. Yeah, it's like a last resort. So that may also change our practice. The viral infection, that's more specific to herpes zoster. So those are cases also where you see these bullae you can see in the ear canal. It also introduces often facial palsy, so a paralysis of the half of your face, but it also produces sensorineural hearing loss and potentially also vestibular dysfunction. If you look at head trauma, of course, head trauma that can, if it's a high impact trauma, it can produce a temporal bone fracture, but just a low-level trauma might also introduce benign paroxysmal positional vertigo. So this is also an environmental risk factor that should be considered. And also the superior semicircular canal, the Hissens syndrome, that's also something we often see in clinic, that maybe there is a small portion of the bone that is still intact on the semicircular canal, but they have a low-level trauma, and then that breaks, and then the symptoms are arising. So this is something that is also related to head trauma. But it can also be that the trauma introduces a whiplash, which introduces neck complaints, which then in fact changes the symptomatology of the patient that might have another type of vestibular disorder introduced by head trauma. If we look at drug toxicity, of course, this is something very important, and it's not the same as chemical exposure. Chemical exposure is rather that it's not prescribed drugs. If we talk about drug toxicity, we talk about antibiotics like chemotherapy, like cisplatin, drug toxicity, specifically aminoglycosides that are very likely. This is something that we call iatrogenic, so iatrogenic induced vestibular loss, meaning that it's in fact due to the treatment started by a medical doctor that you introduce vestibular loss, and often this should be discussed by the one that starts this kind of antibiotics. Often it's overlooked. Often there's no other option, that they have to start the antibiotics because otherwise the patient would die. So there's no other option, of course. But it's something that usually you have to have informed consent that this kind of therapy is highly likely to introduce hearing loss or vestibular dysfunction. So this is very important. And we'll see a little bit later on that there is some genetic part. And also noise trauma, it depends a little bit on what is the intensity of the noise trauma. Because a blast trauma can also introduce damage into the inner ear system, but it can also introduce vestibular loss indeed. And as mentioned, occupational factors are also considered environmental risk factors. But of course, if we think that maybe occupational factors can introduce stress in an individual, and of course, this can alter the symptomatology of the patient. Explain that in a moment. Also, if you look at trauma, you can also think of barotrauma. So people that go for scuba diving, this can also change the pressure inside the middle ear, which then might also introduce some damage towards the inner ear. So you can have perilymph fistula, meaning that there is a pressure going inside the inner ear, and then there's a leak of perilymph outside. Often it's through the round window membrane or through the oval window next to the stapes. Often it's also associated with hearing loss. Sometimes we have to do surgery to in fact just close up this leakage, otherwise the symptoms are not improving. Same with blast trauma. If that's not regular noise trauma, but it's really like an explosion where there was a real blast, you often see perforation of the eardrum, but also perilymph fistula where the vesicular chain was moved that much that in fact there's a leakage of perilymph. Talked about the superior canal dehiscence. This is probably more low-level impact because they already had very, very thin bony part on top of the superior canal, and then it breaks, and then the patient in fact notices the exact moment when it starts, compared to the other part of these SCDS patients where they have a lot more progressive kind of disease onset. And of course, temporal bone fracture, anything can happen there. We see a lot of these high-impact trauma. Nowadays in our region, we have a lot of what we call speed pedelecs. So these are like high velocity speed electric bikes. So if they collide frontally, this is what we saw before as being hit by a bus. So this is high impact trauma, making sure that in fact your cochlea will dissociate from your vestibular system. And then of course you are deaf and you have vestibular loss. So we do see that more often than used to. And this is of course very disabling. Or people just falling off 6-story high building. So that's about the same as frontal collision between two electric bikes. And this is a slide I took from Raymond's paper. Because of course in bilateral vestibulopathy, we do have a lot more. So I've mentioned some of them. In fact, as toxic or metabolic factors, also considered environmental. Hyperthyroidism is of course discussed today. That's not really environmental. So there's a long list in fact of other diseases that can, including bilateral cochlear implant, has also been mentioned that it introduces vestibular loss, although I think currently with the newer techniques that it's something that happens less nowadays. So in our database we saw it's less than 5%. And then you have, of course, the potentially avoidable risk factors. I've talked about aminoglycosides, cisplatin, but also combination of therapies. So furosemide, if you combine it with other medication, you increase the level of risk of hearing loss. And also amiodarone, so that's a cardiac medication that often introduces still reversible vestibular loss. So this is very peculiar. And then, of course, I've talked about the chemical exposure before. This is important because, of course, you can prevent this toxicity from happening if you make sure that the awareness is high enough with the people of the occupational health physicians. You can immunize for the infectious disorders. You can early diagnose them. Then if we go to the prognosis, well, it is relevant, and I think that's part of what Gabriel, of course, is also studying, because of course it's very heterogeneous at baseline when you see the patient at the first presentation. And for us and for the patient, of course, they want to know whether this will develop into chronicity, whether it's chronic disease that will last, and how we can in fact counsel them and get actual best management, best treatment for compensating to their. So what is very important, and maybe it fits a little bit, and also trying to identify the actual is that we need to be aware of the combination of disorders. So this is also very important. As you're designing, for instance, a system where you can have a probably better ranking of disorders. It's nice to know that although we think that there's different phenotypes like BPPV, vestibular migraine, unilateral vestibulopathy, or Meniere's disease, often there's a lot of overlap. And this is very important to realize that because the patient doesn't know about it. You have to find this out. And often, if you look at the diagnostic criteria, when you use that for designing this kind of system, there's a lot of overlap as well in the criteria. So meaning that one patient can fit in 3 different diagnostic criteria, the ones for vestibular migraine, the ones for vestibular paroxysmia, but maybe also Meniere's disease. So then, as a clinician, and that would be very helpful to have this kind of system to make, in fact, to discriminate which, in fact, is the actual diagnosis that is active in a patient. Because it might be that it's a patient with a Meniere's disease that is, in fact, stable. The hearing loss is just around, and it's not changing. But now it's more like vestibular migraine that is active. So this is very important to be aware of that, that there's this overlap, and there's a significant overlap in many of the patients that we see, and that there's additional disease modifiers. So I can imagine that if you add age of the patient, that it will change how the symptomatology will be described by the patient. So like a BPPV in an 80-year-old is not the same presentation as a BPPV in an 18-year-old. So this will be very important. And of course, because of the anxiety that patients are having because of the symptoms. So if they are anxious about vertigo, then of course the level of chronicity that we see developing will be higher in these patients. So this is very important to also manage it. So there was some research on cognitive behavioral therapy in the vestibular training to make sure that they also are aware of reducing their anxiety levels and their confidence effect in compensating after this vestibular loss. So I've discussed this, of course, you have the acute phase recovery, but what we really want to know, of course, towards our patients is what's the outcome in after 3 months. So we need to explain this to the patient. Also for Meniere's disease, most patients want to know whether will this go away, or is there at some stage a recurrence risk? And in the past, but that's many years ago, we told our patients like 1/3 will go away spontaneously, 1/3 will remain the same if left untreated, and then 1/3 is in fact just increasing their attacks. I think it's quite hard, in fact, with the recent studies that when I see with vestibular migraine, there's a lot of overlap, whether these studies were not just vestibular migraine associated with the vestibular, with the Meniere's disease. So we don't know that, of course. And it also depends on maybe also the anxiety and depression. If these patients are prone to depression, they might then develop after a peripheral vestibular loss, a persistent posterior perceptual dizziness, because of their risk of depression, and that it in fact impedes them to compensate after the loss. The comorbidities that might be of interest besides anxiety and depression, cognitive dysfunction, although it might be that it arises a little bit, that parts of the cognitive factors are caused by the vestibular dysfunction, although there are some data out there that also in patients with dementia do have factors that are also visible in, for instance, patients with bilateral vestibulopathy. So I think it's quite hard to disentangle which factor comes from where, and that also chronic pain or cardiovascular risk factors might introduce some increased risk of developing chronic dizziness. And of course, that's why we need to do more research on what's the initial vestibular damage. At this point, it's very hard, and it's the same issue in the cochlea, but it's also in the vestibular system, is that we don't have a lot of information on the pathophysiology, what's happening inside. We can measure what its function is like. We can have a treat for hearing loss. We can have VHIT or ENG, but in fact, it's not something you can treat. What you can treat is in fact pathophysiology, and I think that would be more interesting even if we had some kind of just like you had a blood test for kidney or liver function. It would be more interesting to have a sort of test to really measure what's going on inside the vestibular system or the cochlea. But at this point, of course, this is something that we don't have. So we have to do function testing to identify what is the level of vestibular loss. And of course, we need to do a lot more work on how to identify what are the different categories and which is the best combination of tests to, in fact, develop these sort of groups of patients with level of vestibular damage, and whether that, in fact, will have an impact on function, and how we can monitor these patients with the actual patient-reported outcome measures that we have nowadays that have a lot of limitations, like the dizziness handicap inventory mentioned. So for the genetic factors, they are specifically in contrast with the environmental factors, although not all of them are. So what I've looked at is, in fact, in the field of genetics, looking at the specific mutations that in proteins that we know cause hearing loss, but are also involved in vestibular loss. And I think what's very important is that in the last few decades, the problem is that a lot has been done looking at hearing loss and doing audiometries, but in fact, virtually none of these patients have had really a comprehensive vestibular testing. So that's an issue. So we know a lot about their hearing, about how they evolve, but in fact, there's not a lot of work done on using VHIT or calorics or any kind of vestibular function measurements in these patients. And I think it's important that it doesn't correlate. So it doesn't mean that if there is a hearing loss that is progressive, that the function is also progressing at the same level. So this is something that we see. It's not entirely correlating with each other. There are specific other timelines there. But these are the types of genes that are involved in vestibular function. So the first part I'll discuss are the Usher syndrome genes. And the reason why, in fact, we probably know a lot more about genetics in the first place is because in the end, it was the cochlear implant that increased the let's say, the motivation to know about what is the pathophysiology inside the cochlea. So that was the reason, in fact, that people were more interested in deafness, because before it was a single disorder that was really physically, these people were moved to another place and ignored. But the time that, in fact, there was a treatment available, that was the time that there was more research started on the actual causes of hearing loss. And of course, with the rise of genetics that coincided with that start of the first cochlear implantations. So I think by now we do know a lot, and each of the cell types, of course, in the cochlea have their specific proteins that are expressed. And in fact, if we do genetic testing for hearing loss right now, it tells us a lot more than any audio. Because then if we know exactly which gene is affected and which kind of mutation that is affecting that gene and how it affects protein function, then we can really say to the patient, well, there is in the hair of a hair cell, specifically in that type of hair cell in your cochlea, there is a defect that causes your hearing loss. That's something we cannot give to the patient when doing an audiometry or speech audiometry. So for the patient, if we have a diagnosis, I think it's very interesting to them that it's not something mysterious, that for the first time we know what is in fact causing your hearing loss. We can also know whether there's any risk for children, whether to inherit this hearing loss. So I think it has moved the field a lot forward in that case. It can also tell you whether your cochlear implant might in fact work less than you think if there's specific mutations in genes we know that are more in neuronal function. We do anticipate that the cochlear implant will have a harder time to stimulate the nerve. So there's a lot of work and a lot of studies that have been performed trying to compare the groups that are group of genes that are affecting more spiral ganglion neuron function versus the ones that are more in the periphery spiral ligament, which have a better outcome in supporting cells as well. So I'm not going to talk about all of the genes, but for Usher syndrome, this is very important, of course, as a disease, because not only introduces congenital profound hearing loss and also vestibular reflexia, but also progressive blindness. So, of course, this is one of the disorders that has been a target because of the combination of deafness and blindness. This is, of course, something that's very debilitating. And, of course, for the hearing loss, we do have a cochlear implant. It has its limitations, but still we have some kind of rehabilitation measure. But for blindness, of course, this is a lot more difficult. So that's why they are also performing clinical trials right now using gene therapy injected in the eye to, in fact, trying to restore or maybe prevent the blindness from happening. Of course, because they don't have another treatment option, they are really moving at very fast because there's no other solution. And you can see that there's different genes involved. And these are all genes that are involved, in fact, and I'll go to this one. It's really given us a lot of knowledge on how the hair cell and the hair cells, the hairs on top of the hair cells work. Because all of these genes, you can notice that they have a specific location in the tippling, so connecting the stereocilia. So you can really identify what is the impact if this protein is affected in structure, how it in fact affects the function of this complex. So this, of course, has really made us evolve in our knowledge in how the stereocilia work, and there's still a lot of research ongoing right now. And I think what we're moving on right now is going towards more the connection with the mechanotransduction channel, in fact, how that the tippling that you see here, that's more protocadherin 15 and cadherin 23. So that's the linker, but how it in fact connects inside the stereocilium with the mechanotransduction channel, something that we are currently in our lab, for instance, researching how this connection is made. So that's not known at this point, how it opens up the channels, and that introduces, in fact, the needed for depolarization of the hair cell. So, but all of these genes are in fact involved in Usher syndrome, and they have their specific phenotype, meaning that not all of these mutations give the same kind of phenotype. So it can be that some of these mutations not necessarily introduce a congenital hearing loss, but rather more progressive hearing loss in the field. And the limitation as for now, so what has been the limitation of doing this research with genetics? So a lot of this research was done using knockout mice, but not all of these mice, you cannot knock out all genes because some are not viable. So these mice are not living, so meaning that you cannot study them. Of course, that's why they have these conditional knockout mice, so you can introduce it later in life. But that's why we're looking nowadays more to proteomics, so single cell proteomics to identify within each hair cell whether there are other proteins that might be involved in this kind of complex that otherwise we wouldn't have been able to study using these non-viable. And what we'll see tomorrow, so tomorrow morning we'll have a patient with DFNA9, so that's a patient with the heterozygous autosomal dominant mutation. So just to give an idea, that's around probably 1,500 patients in Belgium and the Netherlands. So it's quite prevalent. It's one of the most prevalent disorders genetically postlingual, provoking postlingual hearing loss, but also vestibular loss, bilateral vestibulopathy. And we'll hear tomorrow. And I think I invite you to really also ask your question to this patient, because we had a patient in Maastricht before with acute unilateral vestibulopathy. And just think about how a bilateral vestibulopathy, how that would be different from this kind of phenotype of an acute unilateral vestibulopathy. And she will explain, of course, but you can definitely ask all your questions to her. And that will be very interesting. And also, she can provide some part of how to manage a patient advocacy group, because she has been really valuable in now being the chairperson of this group. And then you see some other non-syndromic, meaning that there's only hearing loss, but also vestibular loss, but no other types of organ systems that have been affected. And you can read about this afterwards if you want to have more detail, of course. And in fact, the DFNB 110, that's the ones, so these are patients that have a sort of functional knockout of their cochlear gene. This is interesting because we know that they have congenital hearing loss. Vestibular function, we don't know really a lot about it. It was tested, but there was no vestibular impact, which is a bit in contrast to the DFNA9. But more interestingly is that the parents who have one functional cochlear gene and one knockout, they have no hearing loss at all. So for us, this is very important that you only need one functioning cochlear gene to make sure that you're. And then there's a long list of other genes involved, and I think I want to highlight the ones that is not DFNA9 but DFNB9. So there has been some mix-up in the past for otoferlin. So this is in fact a gene that causes that synaptic transmission is in fact not happening, meaning that the anatomy of the cochlea is in fact just there, but the release of the neurotransmitter is actually not done, meaning that there's no functional connection between the hair cell and the spinal ganglion neuron. So this introduces a congenital hearing loss, and that now has been studied in several groups in China, and also a group that has studied in the US, in Spain, in the UK, where they inject in the cochlea through the same kind of round window membrane approach that we use for cochlear implantation. They use a viral vector to introduce the gene. There are some limitations because the packaging capacity of such a vector is of course limited, but it is possible to in fact make sure that you introduce and recombine a full-length otoferlin inside the cochlea. And I think the result that we saw, and also the report from last week, if you see that 3 out of 12 patients have normal hearing after 1 year. So this is very, very innovating. So I think that we will hopefully have more outcome on their speech and language development, of course, because I think that there's a lot of debate whether some of these patients get a unilateral cochlear implant and they get gene therapy on the other side. So the question is, what is driving speech and language development? Maybe it's the cochlear implant, and the gene therapy is in fact just riding the wave. Hopeful, very, very optimistic. But I think the downside is, of course, that the anatomy is intact in the cochlea, and other disorders for other genetic etiologies, probably there's a lot more damage to these structures, and it will not be entirely this kind of success story at the beginning. So let's not be pessimistic, but yeah, we have to be cautious. And of course, there's some other syndromic forms, so meaning that there's not only hearing loss or vestibular loss, but also other organ systems involved. There might be cardiac arrhythmia that can be provoked. You have also kidney disease. So this is very important because we see these children and they are referred to us because of hearing loss. We do genetic testing, but then you have a diagnosis where you know that you have to also make sure you check their heart, also check their kidney function. So it makes that we do these kind of genetic consultations always with ENT, clinical geneticist, also with the pediatrician, to make sure that we have the whole story straight in these children, and that we can explain to the parents very well what's the inheritance rate of this kind of genetic disorder, and whether or not we have to check for other organ systems that are involved. And for the mitochondrial genes, this might be important. These are also mutations that affect mitochondrial function. And this is relevant because some of these mutations, it can then affect that after exposure with aminoglycosides, that in fact you have hearing loss or vestibular loss. So this is very important. And in some countries, you have like a sort of rapid access testing for this kind of mutation before you start aminoglycosides. I know that in the UK it has been started. I think in Belgium it's not routinely performed, although it is possible. But I think many people are not aware of it. And of course, if you have rapid access to this testing, then it's feasible. If, for instance, if you have to wait for 3 months before you can treat a potentially lethal disease, well, you don't have 3 months, of course. So I think in most cases, most countries will just start with the medication, but afterwards, if they have hearing loss, we can do genetic testing and we know why this has happened. So, but it is possible to do some rapid testing if it's. So for my part, I think if we look at genotype phenotype, I don't necessarily think that you look at the hearing loss function that you have to think of the vestibular function will go the same evolution. This is very important because some have normal vestibular function, but might also be the other way around. So I think we need more research in isolated vestibular loss bilaterally with intact hearing function. But of course, at this point, there's not a lot of these disorders out there. Then for the compensatory mechanisms, that's something very interesting because you would expect that in otopurine, for instance, that there would also be vestibular loss, but these children are compensating very much. So maybe that's the reason why we don't see a lot of functional deficits there. And of course, the reason these subclinical deficits, often that's the reason why it's overlooked and that you do hearing testing, but there's no vestibular testing involved. So I think in the current studies and the future studies that vestibular testing is something that we perform routinely nowadays, and I think it's more easy because of the introduction of video head impulse testing. I think before, if you have to do calorics, then maybe it's a little bit as a routine screening, maybe it's too cumbersome. And of course, yeah, this should be indeed part of genetic workup if the patient has vestibular dysfunction and hearing loss, of course, and there's a family history. This is something that really we have to think of. And we are very fortunate in Belgium that I think for the last 15 or 20 years that we have reimbursement. So this costs the patient 12 euro. So the government will just pay 1,600 euro to do the full analysis. And then we can just have whole exome sequencing of all of these patients. So